Dr. Nitin Abhivant has done his MD in psychiatry. He is the associate professor and head of Department of Psychiatry in BJGMC Pune. He has done his MBBS from St. GS Medical College in Bombay and his MD also from St. GS Medical College in Bombay. He completed FAIMER fellowship in 2017. He has 3 publications in national journals and 2 publications in international journals. And he currently also holds additional charge as Chief Administrative Officer of Maharashtra Institute of Mental Health, Pune. The other chairperson for this session is Dr. Colonel Suprakash Chaudhary. He is a professor at the Department of Psychiatry, Dr. D.Y. Patil Medical College Hospital and Research Center. He is currently the president of the AIPI and has formerly been professor and head of Department of Psychiatry in Rural Medical College, PIMS, Loni. He has also been the professor and head of Department of Psychiatry and Medical Superintendent at Rinpas, Ranchi, and he has been a professor of psychiatry at AFMC, Pune. He is a joint editor at the Industrial Psychiatry Journal and is the president of the Indian Psychiatric Society, Jharkhand State Branch from 2007 to 2008. He has been an editorial board member and has 26 national and international journals. He has been a referee of 101 national and international journals and has 24 professional honors and awards under his name. He has published 581 papers, edited 12 books in 16 chapters. He has 2,788 Google Scholar citations, and he has an H index of 24 and an I-10 index of 65. May I now request our respected chairpersons to chair the sessions and take over the proceedings.
Thank you, Tahura. Our speakers for the first session are Dr. Sarah Elizabeth Whitaker. She has done her BSc, MB, CHP, and MRC Psych. She is a consultant in child and adolescent psychiatry, adolescent PICU, Signet Hospital, Bury, Manchester, UK, University of St. Andrews. She did her BSc. Her MB, CHB was from University of Manchester, and she is a member of the Royal College of Psychiatry since 2012. Dr. Samir Guliani, MBBS, MD Psychiatry, MRC Psych, is an alumnus of D.Y. Patil Medical College. He is at present Specialty Registrar in Child and Adolescent Psychiatry, South London and Maudsley, NHS Foundation Trust, UK. He has done his RC Psych MTI Fellow during 2017 to 19. He was a consultant psychiatrist at Fortis Healthcare, New Delhi from 2015 to 17. And before that, done his MD from this college. And he did his MBBS from HIST University, Dehradun. Dr. Christopher Ryan Zachary Carew. I'm sorry, I may have got it wrong. He has done his MBBS. He is a specialty doctor in adolescent PICU, Signet Hospital, Bury, Manchester, UK. He is director of Medical Men's UK and Carew Consulting. He was in University of East Anglia from 2011 to 2017. He is a Royal College of Psychiatrists affiliate. I will request the speakers to present their talk.
Thank you so much, sir. And thank you for chairing the session. It's nice to have you chairing the session. And it's really great to present in own medical college. So thank you for the opportunity. So we'll be presenting about COVID and child psychiatry from a UK perspective. And I will start the session by discussing the impact on young people and how it has impacted the community setting. And then I will hand over to Dr. Whitaker and Dr. Carew for discussion about the inpatient setting. So as we all know that UK has been quite significantly impacted by COVID since the beginning of the pandemic. And there has been the impact on young people has been firstly isolation. So isolation has been, they have been cut off from all social networks. There's no school. The school in the United Kingdom has been shut for almost a year now, barring a few brief periods in between. But overall, it has remained shut and is due to open this Monday. And the students have had sort of twofold thoughts about isolation and education. So some of the young people who I see tell me that it's been how hard it has been for them to not meet their friends, not meet rather anyone sometimes. And on the other hand, some people who were being bullied or found school difficult have taken lockdown as a blessing. There has also been risk of violence to and from families of young people stuck and frustrated at home, and there have been challenges for child protection, which I think in the times to come we will see, what actual uh, challenge that has been on the ground, because often the abuse and the uh, mistreatment comes from family or around. Now the young people are stuck at home with those families at some times. There has been lack of support and opportunities for young people with risk behaviors in the community. Not only that there has been a lack of support and opportunities, but there also been increase in the number of risk behavior cases across the UK, and there are only limited professionals to support uh, that increase in the risk behaviors. There has also been significant difficulties in planning transitions between inpatient and community settings. So lockdowns, there have been constant lockdowns in the UK since last year, and we are currently in one as well, which isn't ending till June of this year. And however, there are, as I discussed in the previous slide, there are two sort of aspects to it as well. Many young people in secure settings, like in custodial wards or in inpatient units or in daycare units, have reported feeling anger at society's reported challenges with national lockdown, as these restrictions are something they experience every day. So I think it is important to see that the experiences that they've been having for so many years or so many months previously have been sort of normalized, and now when people are discussing those experiences over and over on the TV, on everywhere, they feel their experience is validated. There have been significant number of deaths in the UK, and I've personally seen many young people presenting to the emergency uh, due to in a crisis situation due to a family member passing away due to COVID. And it has been different kinds of presentations for those young people, and often it is quite challenging to support them in this time because of the limited uh, interaction that we can have, and there have been so many barriers to that support that we can provide. In terms of emergency assessments, firstly, there have been limited capacity in the emergency departments because the hospitals have been overwhelmed with COVID cases. And it's often the case that a young person might be turned away, might be wanting to present to the A&E and feeling suicidal or with significant mental health problems, and would be turned away to a different hospital, which is often not the ideal case in that scenario. And there is definitely an increased risk of exposure for the young person who's attending the emergency department where there are so many COVID cases, and the clinicians who are also attending to see that young person while attending that assessment. Uh, Another challenge in terms of emergency assessments has been Mental Health Act assessment. So in the UK, the children can be admitted to hospitals under Mental Health Act when they deemed not to have capacity, or they have significant risk behaviors, whether risk to self or others. And this has been a challenge because Mental Health Act assessments in the UK are designed to be an assessment undertaken by three professionals. So it's usually a nursing staff member and two doctors. And that has been a challenge in COVID. Initially, initially the NHS and the Royal College of Psychiatry decided that it could be done remotely. However, due to a recent legal challenge to it, it has been overturned, and it has been decided that all Mental Health Act assessments would be continued in person. Speaking about the barriers to engagement, so the first barrier, I think, is the one that we are facing right now, that we can't be there in Pune, and we are having to do everything virtually. Uh, it is often difficult for young people, especially to have confidential conversations over a virtual link. It might be easier for young people who already know the professional and are being seen for a follow-up, but the virtual contact is something really difficult for people who are just starting to meet a professional. There have been limited face-to-face reviews or home visits. Since the beginning of pandemic, it was the guidance that all assessments should be virtual if possible, and and over the period of last year, they have been gradually starting up. And now that all the OPDs and everything has been equipped with screens and protective gear, and now the limited face-to-face reviews have been possible. Then there is struggle or lack of technology. So not everyone that we see have a laptop or is able to operate a laptop. Sometimes it's difficult. The video isn't starting, the audio isn't working. So I think that I'm sure we all have faced that scenario over the last year. And as was widely known across the world, I believe the UK had a significant shortage of PPE in the beginning. So, especially for the first 3 months of the pandemic, the lack of PPE was also a huge barrier of engagement for people working in child psychiatry with the young people. I do see in the conference sort of schedule that you already had a session specially dedicated to difficulties in young people with ASD or learning difficulties during the pandemic. So I thought I'll just briefly touch on it and not go in much detail for that. And the current challenge that we are seeing in people with ASD or learning difficulties is that now that schools are starting to reopen after a year, it is again a huge change for them, and they are worried about settling in school post-lockdown. Most people with ASD or learning difficulties that I've personally seen have found lockdown to be more containing, more helpful. And the other aspect of it being the assessments for ASD and learning disability were not possible in majority of centers, delaying the waiting lists and extending the time to assessment. And in some of the centers, it still hasn't started. Now, we wonder about the long-term challenges and long-term consequences of this pandemic on how we practice and how it will impact the young people in the long run. There's bound to be mental health challenges in the future. We've already seen an increased number of cases, an increased number of risk behaviors, self-harm, suicidal attempts, and like any disaster, the pandemic is due to hit hard on children. And changes to practice of psychiatry with telepsychiatry and an array of new technologies, we have been able to reach children and young people at times where they would not have otherwise engaged if it was if they were offered an in-person appointment. And now with the use of technology, in some cases, that has been rather helpful. So it would be important to see in the coming months and years how this pandemic will change the scenario of our practice. I'll briefly mention the impact on doctors and professionals themselves. I think Dr. Karu will be mentioning this further later in the presentation, but I think all professionals, including psychiatrists, have been significantly impacted by the pandemic, and the workload has been exhausting. And I think that has been a challenge across the world. Just wondering about the benefits of the pandemic, just looking at the positive side of it. So there are new ways of engagement that we've managed to find and managed to implement. So as I said, that virtual technology has been helpful in getting through to some of the patients who wouldn't have otherwise engaged. There has been improved multi-agency working. So people who would have attended meetings in a particular setting, whether it's social workers with the doctors or the psychologists, or all aspects of the child care, including schools or teachers who are at home but are attending meetings for the children. So there has been improved liaison between all professionals. And also there has been normalization of experiences because we all have faced anxiety or sadness or isolation at some point in time during this pandemic and when the restrictions have been imposed. And this has translated into young people feeling more validated about their own sadness or anxiety and isolation, which they usually feel and are often dismissed. But now they are seeing that when other people and general population as a whole are feeling those emotions, it has been quite validating for them. I'll hand over to Dr. Whitaker and Dr. Karu for discussion about the inpatient setting.
Excellent. Thank you very much, Dr. Giuliani. I'm going to talk about the impact of COVID in inpatient settings. I'm a consultant in child and adolescent psychiatry working in an adolescent psychiatric intensive care unit. That's a 6 to 8 week unit for young people who need more support, either in terms of self-harm or aggression that can't be managed in the community or in a general adolescent unit. A low secure unit is a longer term unit for girls and boys. The majority are young women who have a history of complex trauma, emergent personality disorders, and the average admission is for about 6 to 18 months. With the low secure unit, there's a marked emphasis on therapeutic input and rehabilitation. The general adolescent unit is again a short stay unit, a bit like the psychiatric intensive care unit, but has less security. The mental disorders that we've seen, affective disorders, depression, bipolar affective disorders, psychotic depression, psychosis, drug-induced, first presentation, schizophrenia, emergent personality disorder, complex PTSD, anxiety, OCD, ADHD, autistic spectrum disorder, in young people with learning disability.
So I'm going to have a little talk about some of the protocols that have impacted service users surrounding COVID. So Public Health England states that all patients should be tested promptly for COVID, either at point of admission or as soon as possible. So with our service users at Signet Bury, any new admission requires a COVID PCR test. There is not a license for under 18s for the lateral flow test, so we do need to use the PCRs, and the current turnaround for a result is 24 to 48 hours. So within that 24 to 48 hour period, we expect the service user to isolate in their bedroom. Now that in itself, you know, when we have service users coming from all over the country, coming to a new place, the first thing they need to do on admission is isolate. So that's going to provoke anxiety. A lot of service users won't understand why they actually have to have the test, especially if they're asymptomatic. And we often find that family members as well don't fully understand the need for a test, and they're not happy with the service user having to isolate. The isolation period poses its own problems as well. So over here we have seclusion rooms. So seclusion rooms are for individuals that pose a risk to other individuals or staff members on the ward. And the aim of a seclusion room is to protect other people. So in cases where service users have tested positive for COVID or are awaiting a COVID result and are symptomatic, then if that service user does not isolate in their bedroom and they're coming out into the ward area, then they're putting the whole of the wards and staff members at risk of contracting COVID. So we have found in extreme instances where a service user is unwilling to isolate, we have had to use seclusion to protect the ward. So we also have a RAG system, which is a red, amber, green system. Again, this is dictated by Public Health England. So a green ward is a ward that has no suspected COVID cases. An amber ward is a ward that has suspected COVID cases that aren't confirmed. And a red ward is a ward that has suspected COVID cases that have been confirmed. So if a ward is considered red, again, this is if there are staff members or patients that have tested positive for COVID, then no individuals are allowed to leave that ward area. That means that no Section 17 leave is allowed and family visits are not allowed. So again, if you put yourself in the service user's perspective, you know, it's impacting their progress if they're not allowed to access leave, and it's a very difficult time for them if they're expecting family visits and then these are taken away. We have found ourselves in very difficult situations where, again, because we have service users from all over the country, often family members travel 2, sometimes 3 hours to come and visit us. Sadly, we have had times where a family member has traveled for 2-3 hours. They've come to visit their child, their loved one, and we've had a staff member test positive within that time frame. So what we found is that we've then had to tell the parent once they've arrived at the hospital that visit is unable to occur. We've had to tell the service user that visit is unable to occur, and we've often found that this has led to an increase, sadly, in incidents. It also damages that relationship between parent and service user, and it's hard to maintain trust when things like that are happening. Also, when the ward is not in red, visits are limited to 1 hour per week, and it's only members of the immediate family that are able to have face-to-face visits. Again, that's to limit contact and limit the spread of COVID. Virtual visits can occur if the ward is in lockdown. Another issue that we have is that if a service user is part of a discharge or transition pathway where they're visiting another placement, often we, as part of that transition pathway, the service user will visit that placement overnight. Anyone that has left the ward for more than 24 hours, upon return, they again have to have another COVID test. Again, this has to be a PCR test, so the turnaround time is 24 up to 72 hours, and they will have to isolate.
Excellent. So now I'm going to talk about the challenges patients face in all processes of their admission, the treatment, and also the discharge planning. The hospital accepts both planned and emergency admissions. However, as Dr. Carew says, no young people are able to be admitted when the ward is considered to be red. That means that they may have to stay in settings which are not suitable and potentially very risky For example, having to remain on a paediatric ward, having to stay at home, perhaps under section, which is very challenging, or in different areas of the country far away from home, which causes a lot of difficulties for both the patient and their family. As Dr. Carew stated, that when a patient is admitted to a hospital, that they do need to be isolated. Again, there's issues around the capacity. If they're following the guidelines, we have to consider if they're detained under the Mental Health Act. And as Dr. Carew explained about the role of seclusion to protect the safety of other people. And again, because of the restrictions, visits can't take place. As we all know, in all kinds of psychiatry, and particularly I would say in child and adolescent psychiatry, family do have a very important part to play in part of their rehabilitation. For example, family therapy can take place, but because of COVID restrictions, these visits have not been allowed to take place. Of course, we have to be creative in other methods of communication, but there's times where young people, their families don't have access to any electronic devices, they don't understand. For example, the connection's poor when they stay remotely, so they're not able to access Skype or FaceTime. And also the patients can't have any leave. Leave is very important, obviously, for rehabilitation back into the community, but for also assessing patients' risk in the community as part of their ongoing risk assessment and discharge planning. Can we have the PowerPoint shared?
Just a minute, ma'am. There's a technical glitch. We'll come back soon.
No problem at all.
Chris, you're on mute.
Sorry, apologies. My internet connection failed. It's back up and running now. I'll start sharing again.
And obviously there's treatment options to consider. Again, in all aspects of psychiatry, it's very much a team approach, occupational therapy, psychology, family therapy, and education. Obviously that's very important in child and adolescent psychiatry, where there is an MDT approach. However, as part of the treatment, there's times perhaps when the psychologist is unwell due to COVID, or the occupational therapist, just a few examples, and therefore the patient isn't able to access that part of treatment, which is part of course, rehabilitation, assessment, and risk assessment. Then also the patient's physical health, that when they themselves test positive for COVID, this means they have to isolate. Again, we have to consider their mental health status. Do they have the capacity to make decisions about isolating and appreciate their risk? There is the managing family concerns, understandably, when a parent's child is positive for COVID and they're not allowed to visit them. We also have to consider restrictive practice with patients perhaps being secluded, as due to their mental health, they're not adhering to the guidelines. There's a lack of knowledge and understanding. We also have to consider staff's views, particularly at the start of the situation with COVID, and there was a lot of different information being given. Staff were understandably very scared of contracting COVID, and that in turn could perhaps, through no fault of their own, lead to a deterioration in themselves, between themselves and the young person because of anxiety and rejecting the patient, which is an understandable concern for the staff. However, that in itself would impact on the young person, perhaps if they've come from a difficult background where they felt rejection in all their lives, so that impacts on the young person. And also when a parent's family or friend becomes unwell and they're unable to have leave to visit, and also have to deal with possible serious consequences of ITU admission or sadly death.
Okay, so I'm going to have a little talk about some of the issues with transferring individuals to general hospital. So we transfer our service users to a general hospital for a number of reasons. Often it's due to self-harm through insertion of foreign bodies, whether it be PV, PR, or up the nose or through the ear. Also for general physical health issues as well. So since this whole COVID pandemic has started, we've had to change the threshold for transfer. And the reason behind this is there's a higher prevalence of COVID on general wards. So we want to reduce the risk to that service user. We want to reduce the risk to the general ward population upon return. But we also have to consider that upon return to the ward, that individual is then going to have another COVID PCR test and isolate in their bedroom for up to 72 hours. So what we found ourselves doing is we're doing more and more procedures on the ward area. New recruits to our hospital in Signet have got a different skill set. So some of the new doctors that have been recruited have got a background in surgery. So they're now able to remove those foreign bodies themselves on the ward area. And this avoids the amount of transfer to general hospital that we've had to have previously. We've also had to put a lot of consideration into the risk of using PPE on the ward areas. So Public Health England says unless there is a medical reason why this individual cannot use PPE, then PPE will have to be used at all times. So we perform risk assessments on every individual within our care. And that risk assessment effectively looks at, is there a risk of ingesting the PPE? Is there a risk of self-harming through ligaturing using the PPE? Or is there a risk of self-harm through cutting using the metal strips in the mask? We found in probably about 95% of cases, our service users are not using PPE and are not using masks in an inpatient setting due to the risks associated with using them.
Apologies. So we come to the last stage of a patient's pathway in hospital, their discharge. That can either be back into the community or into another adolescent unit, either up or down the level of security. Because young people haven't been able to have leave or have time with their families, it's difficult to do a risk assessment on how they'll manage in the community. We also have to consider that, in fact, that the restrictions of no family visits, of COVID, anxiety, can result in a deterioration in patients' mental state. For example, if a young person has completed treatment successfully in the security of a psychiatric intensive care unit, and we want to transfer to, for example, a general adolescent unit to consolidate their progress, this could be delayed because of the ward being red. There is difficulty about discharging patients into the community, and for follow-up, as Dr. Giuliani described in detail, there are a number of challenges faced in the community. There's more limited services, less staff working, these having to be done virtually rather than in person. Although it does have could have some positives. However, it is also sometimes quite tricky. And also the service users' own views about COVID and the follow-up service views about COVID. Looking at the positives, as it's always important to do these things too. We did notice that attendance at meetings have improved, to explain that our young people come from all over the country, and it's obviously difficult for professionals involved in the care of a young person, perhaps 100 miles away, to attend in person. So using Skype or Zoom or Microsoft Teams, this actually has helped with their attendance. On the ward, this is a project ongoing. There hasn't been any significant increase in incidents, and my feeling from the ward I work on is actually the young people and the staff cope very well. However, as I say, this is a piece of work that will be started and ongoing, and the staff are more creative about providing input for the patients. For example, our psychologist was positive for COVID, although not symptomatic, so did virtual sessions from home whilst he was shielding.
Okay, so to conclude, it looks as though we're getting towards the end of COVID restrictions within the UK. The Prime Minister has set out a pathway for the end of restrictions expected to be on June 21st. As we stand now, more than 20 million people of the population have been vaccinated, and it looks like these restrictions will be coming to an end soon. So what have we learned during this pandemic? What changes have been positive? What changes will we take into the future? And what changes have been negative that we won't take into the future? So positives, there's been better attendance at our meetings, as Dr. Whittaker was saying. So we have, within psychiatry, we have many meetings with our service users, with the wider multidisciplinary team, and with externals. And it's often hard to arrange meetings where everybody can attend in person. So COVID has forced us to move these meetings into the virtual realm, and we've actually found that attendance has increased. But more importantly, it's actually been a lot easier to arrange these meetings. So I think this is something that's definitely going to continue once the COVID pandemic is over. Second of all, we've limited the amount of times we've had to transfer service users to a general hospital. So procedures such as removal of foreign bodies, for example, usually take place off-site. Signet have now employed specialty doctors who have background in surgery that are now able to remove these foreign bodies on site. So again, that's a positive that we will take into the future. As Dr. Giuliani was saying as well, because of this COVID pandemic, part of that stigma that is sadly associated with mental health will be reduced. You know, within the UK, we see lots of TV adverts, lots of support groups talking about anxiety, sadness, this whole isolation that everybody's experienced within the country, and it helps reduce that stigma associated with mental health. And I think that's going to be a really positive thing to take out of the pandemic. Of course, there are the negatives associated with all these changes that have happened. But again, these negatives will hopefully be short-lived. The negatives have had to happen to reduce the spread of COVID. And we're hoping that once these restrictions lift, we can go back to a better sense of normality. So overall, lots of negatives to take from the COVID pandemic, but there's also been some positives that we can take into our future practice, which without the COVID pandemic happening, I don't think these changes would have been made. Thank you.
Thank you, Dr. Sarah, Chris, and Sameer for a wonderful presentation. I'll request Dr. Nitin to give his concluding remarks. Dr. Nitin.
Hello, can you hear me?
Yes, yes.
Yeah. So, because of the COVID, the things have changed a lot. The pandemic has affected everyone. So, not only in India, but we can see the change or how it has hampered the mental health services in UK also. So, it was a nice presentation to give us the insight, especially for us Indians, to what is happening in UK and how they are dealing with and how they are handling the pandemic. So it is a nice presentation. I think it is open for discussion. If anybody has any option, any questions, they can ask the speakers.
There are no questions in the chat box. So I will once again thank Dr. Sara, Chris, and Samir Guliani for a wonderful presentation. Thank you so much.
Thank you, sir.
Thank you very much.
Next.
Our next speaker for today is Dr. V.G. Watwe. I don't think he has joined us yet. We shall just wait for him to be with us.
Let us wait for him for some time.
Okay, sir, we shall do that. Dr. V.G. Watwe is going to be with us by 3 p.m. So till then, we can proceed to take a short break.
Yeah.
We can come back after 5 minutes.
Thank you.
Dr. V.G. Watwe is here with us now. So with your permission, may we start?
Yes, yes. Dr. Vidyadhar Watwe, he is the most famous psychiatrist from Pune. Whenever we used to see any patients outside Pune, they would always talk of Dr. Vatve. And as far as I am concerned, when we were doing our post-graduation, Dr. Vatve, we were very thrilled to have his presentations. It was a treat. Subsequently, when we were at AFMC and holding the ANCAIPs, that time, again, Dr. Vatve was a pillar of strength. And now as we are nearing retirement, we again have Dr. Vidyadhar Vatve. Hey, mute. So, Dr. Vidyadhar Vatve did his MD and DPM from BJ Medical College. He is a practicing private psychiatrist. He is a former president of IPS, and he has numerous publications and many other achievements to his credit. I will request Dr. Vidyadhar Vatve to start his presentation.
First slide. Good afternoon, sir. Thanks for the introduction. My topic this afternoon for about 30-35 minutes talk is do's and don'ts in private psychiatry. In fact, do's and don'ts must be there for private or public or government or anything. But generally, since 80% of the people are in private psychiatry, I thought I'll share my experiences when I'm working in private psychiatry plus for last 40 plus years. Next. Let's start with my journey. I did my MBBS, Diploma in Psychological Medicine and MD Psychiatry from BJ Medical College, Pune. I started my private practice with DPM in 1976. I would have continued like that, but I give all the credit for me to get into MD Psychiatry and to the exam as well as preparation, everything, to three people, namely Dr. Mohan Agashe, Dr. Vinod Chaugule, and Dr. D.M. Dhawale, close friends of mine. In fact, friends, I took psychiatry because I thought there's no emergency in this. I had two options, skin or psychiatry. I said, psychiatry will have least emergency problems, but I was proved wrong. Next. Then, I joined 1976 to 80. I was in Film and Television Institute when late Shri Girish Karnad was the director of a Film and Television Institute of India. Mr. Karnad said that we would like someone to come on the campus, Film Institute, who has some qualification in psychology. I was DPM then I decided that with Mohan Agashe and Girish Karnad, I discussed with them and I joined Film and Television Institute as a medical doctor. The main benefit that I had there, I used to go there for 15 minutes, maximum there were no patients. People used to discuss with me about the various problems like substances, etc. But I met Nasiruddin Shah, Benjamin Gilani, and many others, including Rima Lagu, etc. What happened next is the students, they were healthy young students. They had not much of a medical problem, never. But then they used to involve me in helping the scripts of their short films, 10 minutes films, etc. Then it increased to inviting me to act in the diploma films. I did enjoy that because I was involved in theatre and cinema and television, serial, etc. I won the Best Actor Award in Purushottam Karanda, a prestigious intercollegiate one-act play competition. But all these things I enjoyed for 4 years, but it was extremely time consuming, taxing. And I used to do shooting for one shot in one place, come back on a scooter to my clinic, see 2 patients and go back. This was just too much. Then I decided either I should choose only psychiatry or something else. But then I said, with help of Vyang Vaya, whatever little talents, acting talents I had, or if I believe I had, I used to use those acting talents in various presentations along with Dr. Vyang Vaya. 1994 onwards, I have never acted in any serial or anything. Previously, I used to do that. But now I was using my talent in doing presentations with Dr. Vyang Vaya. And we did many 50 plus presentations. Next, please. So, with this, my early part of my career, I have something for you to share with me as do's. I will request all of you, in those who are coming in private practice, plan goal-directed path in your career. Because getting postgraduate seat is very difficult nowadays. It was not so in my time. I would request all of you to concentrate on your studies, improve presentation skills, because you have to do some poster presentations, some presentations in various conferences. So improve your presentation skills. And my request is take any opportunity to be either speaker, chairperson in academic seminars that go on every now and then. I thought teaching is the best way of learning. This I started doing when I started working in Sassoon General Hospital as a visiting lecturer, along with Dr. Mohan Agashi and Dr. Rajan Kali, who was a neurologist. I used to come into contact with various students who are now faculty in various places. But because of them, the students used to ask me questions. I started reading, and then I became obsessed with reading and presenting various in various seminars. So my advice is pursue your hobby, just I did, but keep an eye on patient care and reading and updating yourself. Next. What are the challenges in psychiatric practice? For a newcomer, stigma. The main challenge is stigma. In a party, people will say, he's my cardiologist, he's my neurologist, but nobody will say, he's my psychiatrist. On top of that, there are multiple challenges and criticisms from medical colleagues and fellow mental health professionals. If you know, the new term is mental health professional, a psychologist, social worker, psychiatrically trained nurses, they're all mental health professionals. And some remarks by psychologists कि ये डॉक्टर लोग मत जाओ, वो दवा देते हैं, सोने की दवाएं, will cure you by counseling, samupadeshan. So these are the challenges. You have to face them. Every now and then, social workers, psychologists, they pass such remarks. That's a main challenge. But rather than getting angry with them, I would definitely advise the colleagues, coordinate with all these specialists, which is a part of a CL psychiatry work or general hospital psychiatry units, where you are there as a psychiatric main person, you have a psychologist, psychiatric social worker, and so many people, and intensivist, etc. So you can work with them. Tell them that you have a place in the mental health professional team, rather than getting angry with them. And lastly, there are interpersonal conflicts in your own teamwork. I'm working in a hospital where there were 20 staff members, 4 nurses, 5 psychiatric or 2 psychiatric social workers, then 5 ward boys and attendants and ayas. So they have their own problems. And if you are working in a hospital like this, or you have a hospital setup, you have to take care of the interpersonal conflicts in your own colleagues. Next. I would advise to discuss with other mental health professionals. Explain to them what is the role of psychiatrists in the team of a mental health professional, and the role of psychologists and social workers in psychosocial intervention. They definitely have a role. you cannot work alone. A psychiatrist cannot work alone. You have to take help of a psychologist and social worker. Explain to them, give them the importance, and explain to them the importance of their work in this mental health professional team. Update psychologists and social workers about their importance in current scenario of Mental Health Care Act. If you know, Mental Health Care Act is is implemented, and they are all mental health professionals. Explain to them their role, how important they are to be the part of the mental health professional, because they can also start psychiatric establishment. Take the help of your colleagues like psychologists and social workers in cognitive behavior therapy, rational emotive behavior therapy, and other therapies. And finally, their importance, especially for psychiatric social worker in various rehab programs. Patient-centric approach is a must. Treat with equality. The poor person has come to you because you are going to give him some relief. You are going to listen to him. Treat them with equality. Accept the symptoms. Accept the symptoms seriously. Whatever funny, whatever bizarre he's talking, but accept the symptoms. Because of these symptoms, he's in distress and has come to you for help. Respect the dignity of the patients. Respect the uniqueness of our branch, that is psychiatry. No other branch can have this type of uniqueness. And confidentiality. Very, very important, the confidentiality. But in some instances, for example, I had a Deccan Queen driver who told me previous evening that I'm hearing the voices and they tell me, go out, just jump the signal, railway signal, mind you, and just go ahead, continue Deccan Queen drive from Pune to Mumbai. I jumped the clause of confidentiality. I informed the station people, such and such patient is under my care, is going to take the train from Mumbai to Pune to Mumbai. Please don't allow him to board the train. So here, for the general interest of the public, you can jump the clause of confidentiality. Please go ahead and do it. Very important private practice is the issues of transference and counter-transferences. Both these things are there for years and ages, but these days I find there are more such cases, especially of the transferences. Be aware of that. Patient is a patient, he is a client. You have to cut the relation there and there. And also be aware that you can be into counter-transference situation. Please avoid that. Body language, the way in which you greet the patient when he enters or when he leaves, it's very important. I'm going to tell you an example. My great friend, Dr. Vahia, was looking after of a son of a surgeon and who was extremely afraid of next day's exam. My friend sat with him in his clinic for 2 hours in the clinic, and he said, you are all well-read boy. You are going to do your best. Okay. And after 2 hours discussion, he said, great, God help you. The son went out and said, even Dr. XYZ feels that only God can help me. And he tried the deliberate self-harm. So be very careful what type of language that you use and what type of body language the patient interprets from your body language. Next. Child and adolescent psychiatry. Friends, it's not my case, but what I know, child and psychiatry, adolescent psychiatry, geriatric, these are the super specialties these days. I would request those who are interested in child psychiatry to involve a child psychologist, teachers and parents in your group. Conduct workshops for teachers and parents. This will help early detection and treatment. Correct? This early detection program. Many of my young colleagues in Pune are doing this type of work, conducting workshops. And for your information, DM Child Psychiatry is available in Nimans. And there is a 1-year fellowship in child and adolescent psychiatry in various institutes, including Bombay. Next. In geriatric psychiatry, there is no separate classification. Whatever adult psychiatric classification you have, same applies there. But the main problem in geriatric psychiatry is dementias and delirium. They are the everyday challenges. There are many. You can have anxiety disorders, substance use disorders, schizophrenia, late onset, bipolar, whatever. But mainly, the challenge is treating dementias and delirium. I would advise in a small place, even in district places, we have good neurologists available now. But if you are working in a hospital, please don't be under impression, I know everything of dementia. Friends, you all know dementia is a group of disorder. But the subtyping is very important. Frontotemporal versus Alzheimer versus posterior variant of Alzheimer versus PICS versus rapidly growing dementia. As a psychiatrist, we are taught very well in subtyping of dementia. Please take help of your neurological colleagues. Same with delirium. Delirium, due to substance withdrawal, we do every day in and day out. But delirium in general hospital setup, you can get post-operative, you can get post-orthopedic operations, post-eye surgeries. Delirium is extremely common. And by definition, it's a reversible disorder if the cause is treated. Take help. Take help of the intensivists who are treating in days in and day out. Take help of neurologists who are treating dementias and depression, dementias and delirium. Take their help. Please don't hesitate. Don't be under impression, I know everything and I'll treat. You will be in trouble. Take help. Involve the team. That's a general hospital psychiatry unit or a CL psychiatry work. And again, for information, DM in geriatric psychiatry is available in KGMC Lucknow and few other places. And 1 year fellowship was also, or I think still it is available in 1 year fellowship in geriatric psychiatry in KGMC Lucknow. Our own Punite, Dr. Dhananjay Chavan, has done his 1 year fellowship in geriatric psychiatry. Next. Coming to addiction psychiatry. Again, a new branch, a challenging branch. But I would definitely advise to be to attend Dr. Atul Ambekar from AIMS and Dr. Vivek Benegal from NIMAS. These two are masters in addiction psychiatry. I like them because they are excellent teachers. Excellent teachers. I would advise youngsters to try to interact with these stalwarts in various conferences and workshops and attend their seminars without fail. Please attend the seminars. Especially Vivek Benegal is a born teacher. He's a born teacher. You will never forget when he teaches you for 1 hour in substance-related disorders. Don't give false hopes about recovery. कि ये आपका अल्कोहल का प्रॉब्लम है, बिल्कुल ठीक हो जाएगा. Because you have to be careful because there are many de-addiction centers which are run by people who are ex-addicts. They are doing an excellent job, but sometimes they are not getting help from psychiatrists or other specialists. And sometimes somehow people, whatever their way of thinking, people feel कि उधर डाल दिया सब ठीक हो जाएगा. Don't give them false hope because only 10% improve even in the best of the world centers as far as alcohol is concerned. And many such addictions are concerned. Recovery rate is low. Tell them recovery will occur, but relapse also will occur. Don't get nervous if you get a relapse. Next. Coming to drug therapy, I would definitely tell you what are do's here. Use minimum drugs in adequate dosage. There is no point is using 10 drugs, half in the morning, 1 in the afternoon, 1/4 at night, etc., etc. Because it's our own experience. If you have to take one antibiotic, one curative for 7 days, you are bound to miss 1 or 2. And how will our poor patient who has got a cognitive problem will remember what 1/4 to take in the morning, what 1/8 to take in the night? No. Use minimum drugs, which are important, but use them in adequate dosage. Number 2, chemist shops in your own premises is not ethical. Is not ethical. If you read the old MCI guidelines, But these days people, मेरे चाचा के बहन का लड़का है, उसका केमिस्ट शॉप है, उसका ही होता है. But that is not ethical. Do or not to do. I always say, never do this type of medical shop or chemist shop in your premises. It doesn't look good. Please use standard drugs because they have good bioavailability. There are 110 firms in Himachal Pradesh. Bring the powder here. एक कोई भी नाम से कुछ भी देते हैं, but we don't know the good whether the bioavailability is up to the standard, up to 97%, 90%, etc. One more thing: avoid dispensing drugs as far as possible. There are many doctors, they have no alternative but to dispense. But if you have to dispense the medication, don't remove the catch cover of the medicine, because friends, patient has a right to know what medicine he is taking. There are many doctors who remove catch covers, put it in a small dabbi and give it, sell it for 5,000 rupees, 10,000 rupees. The patient doesn't know. If the patient gulps all the drugs, all the tablets from that dabbi, and patient lands up into deep coma, the intensivist will not know what medicine has got what. So please don't do this practice. Okay. And finally, treat medical representatives with respect. They are there. It's a profession. They visit you every 2 days, 3 days, 10 days. But don't make them wait for hours and hours. Give them fixed time. But only thing is, treat it. It's their profession. The medicine, the practicing doctor, your profession is medicine, consulting. It's their profession. They are there marketing the drugs. But please treat medical reps with respect. Next. Various consents, ECT, oral and written consent in vernacular language. You should take consent for every ECT procedure that you are doing. Don't take blanket consent for 10 ECT electroconvulsive therapies and in one paper. Orally, you have to explain, and written also, you have to do in vernacular language. Explain to them. Ask your sister to explain to them. Various drugs. Clozapine, consent is a must. Anti-epileptic drugs need oral and written consent because of the skin-related issues. Many people give disulfiram without consent. In fact, if you prescribe disulfiram, that prescription will not be honored in a chemist in the nearby area, because the specific way in which disulfiram is to be prescribed to patients. Explain adverse drug reactions. You say skin rash, it can be severe skin rash. Don't frighten them, but they should be aware of what drug reactions can occur. Sometimes they can be dangerous. But in case something goes wrong, like a drug reaction, don't run away from the patients and relatives, but handle the situation skillfully. In 40 years of practice, I had 2, 3, 4 occasions in which I had to stand there and explain to them what the problem is. If you run away, they'll feel it's doctor who has done some mistake and the wrong prescription was given. That's why my son, daughter, or whatever is suffering. Professional indemnity of 1 crore is recommended. 1 crore for MS general surgery, obstetrics was in practice till last year. But what I have learned from my own colleague from Bengaluru, that somebody has asked him to pay compensation of 1 crore. So professional indemnity of 1 crore is recommended. The premium is around 7,000 rupees. One most important thing, if you have a scooter or a motorcycle or vehicle insurance, you can throw away the paper next time when the period is over. But in professional indemnity, my colleague from General Insurance said, we are there not to accept a claim like that. So you have to keep that document of the document of this professional indemnity paper with you till you are in practice. Somebody will come and tell you 8 years back you have done this, and if you don't have that policy paper, the insurance company will say hamare paas kuch nahi, it's your duty. So please keep them, don't throw away like scooter insurance policies or vehicle insurance policies. Coming to certificates and records, certificate is a right of the patient. You cannot give certificate to patient's husband who comes and asks you for a certificate. Ask him, come here, there is a definite format of certificate since 2012. MCA has given that, in which you have to write the identification mark of the patient and take his signature and issue the certificate to the patient, to the client. In the north, I've seen that they ask for a photograph. Anybody can come and say that I am a patient and take a certificate. In fact, I went for a witness, as an expert witness in Delhi. They said कि बहुत लोग आकर ऐसे देते हैं गवाह, आप कौन है डॉक्टर वाइट, ठीक है आपका फोटो लगाओ इधर. Even I went there as an expert witness. They asked me to put a photograph on whatever papers I had written. Records, you have to keep the records. OPD records for 3 years is a must. Indoor for 5 years, and medical legal records for indefinite period. Coming to accounts and taxes, the boring part, receipt book is a must. You should have receipt in which you have to put a carbon and give it should be numbered. It should not be a receipt book by whatever the bhed wala or pani puri wala gives you for buying 50 pani puri plates. Receipt book numbered, your name, your registration number. Then next is OPD register. What is OPD register? Is available, ready-made, but otherwise serial number, name of the patient, services given, consultation, EC, whatever charges collected, cash or check or whatever. That is OPD register. Cash book, every evening, what expenses you have done, that you have to write. Petrol, 2000 ka bhara, likho. Paise mile kitne? 5000 mile, likho. That is called as a daily cash book. And expense book. Expense, whatever the reasonable expense, like whatever electric bill or whatever petrol, etc., whatever insurance premiums, medically related you are giving, that should be written in his big book. Most important, all these books, receipt, OPD register, cash and expense, are to be preserved for 8 years. Income tax may come with query anytime. You have to be able to, you are supposed to preserve all this for 8 years. Coming to professional tax, after 2 years in a career, I have started my practice today. I am not supposed to pay professional tax for first 2 years. I may be psychologist, psychiatrist, whoever, but after that, you have to pay the tax in advance for the financial year. I have completed my 2 years in this March. I will have to pay advance for next 12 months till 31st of March. If you are 65 plus, you are not supposed to pay professional tax. But if you have a driver, you have a nurse or whatever, you have to pay advance tax for them, professional tax for them in advance in the month of April, and deduct them the same thing from their salary. It's your responsibility to pay your staff and deduct from their salary next. To end, friends, your skill and devotions is appreciated by patients and relatives. That's a great experience for you and me. They will be grateful for what you have done, and thus you can have a very satisfying professional career. As Hippocrates has said, cure sometimes, relieve often, but comfort always. That's what I fully agree, and I think we all should try to do our practice in this way, because ours is a noble profession and it's not a business. Thank you very much for patient listening. Thank you.
Thank you, Dr. Vatve, for a wonderful presentation. I will request Dr. Nitin to give the concluding remarks, please.
Sir, it's always a pleasure to listen to Dr. Vatve, sir, to learn from his experiences, and just to listen to him and be with him. So it's a nice presentation, sir. Actually, we all are working in the institute, especially BJ in the government setup. So maybe the learning or the teaching which happens at the medical college may not be appropriate once they enter in the outside field. So maybe like such a we thank the organizers for organizing such a lecture, which will helpful for our residents, for our students when they enter in the practice, about practice and other that. So thank you. What we like, sir? If there anybody has any questions, then we can take the questions, or we can call it out. Chaudhary sir, if there are any questions, then we can take it, or like we can stop it.
Dr. Nitin, there are no questions in the chat box at present. So
Okay.
we thank
Yes.
Dr. Vatve for a wonderful presentation as usual.
Thank you.
With that, we come to the end of this session. Dr. Tahura to take over.
Thank you so much, sir. We are extremely grateful to our respected chairpersons, Dr. Colonel Suprakash Chaudhary and Dr. Nitin Abhivant, for conducting the session so smoothly. We also extend heartfelt thanks to our speakers for their valuable talks, tenets from which we will carry with us for good. The do's and don'ts of psychiatry can truly serve as the 10 commandments for resident psychiatrists like us. We now have arrived at the commencement of the fourth session for the day, for which we have been graced by chairpersons, respected Dr. Sharmishtha Deshpande and Dr. Archana Javadekar. May we please have their CVs on screen? Dr. Sharmishtha Deshpande, she has done her MD in psychiatry from BJMC Pune. She is the professor and head of Department of Psychiatry at Srimati Kashibai Navle Medical College and General Hospital in Pune. She has earlier worked at MIMER Medical College, Talegaon and BJMC Pune. She has a 20-year teaching experience. She has authored 19 research papers in various journals and has presented in various national and international conferences. She received the Best Research Paper Award in BJMC Research Society Conference in 2004 and 2010. Her other achievements are as follows. She is actively involved in teaching communication skills and stress management to students, interns, and residents of the medical colleges, as well as other colleges and schools. She takes keen interest and has expertise in liaison psychiatry, especially psychodermatology, one of the founder executive members of Psychodermatology Association of India, and she is actively involved in guiding undergraduate and postgraduate students' research in psychiatry. Our other chairperson for today is Dr. Archana Javadekar. After her MD in psychiatry, she has worked as a lecturer and then as an associate professor in the Department of Psychiatry at BJGMC, Pune. She is currently working as a professor in psychiatry at Dr. D.Y. Patil Medical College, Hospital and Research Center. She is practicing as a consultant psychiatrist at Joshi Hospital and Shri Clinic. She is a postgraduate teacher in psychiatry and she has a life fellow membership of the Indian Psychiatric Society and also of Association of Industrial Psychiatry of India. May I now please request our chairpersons to kindly take over the proceedings.
Thank you, Dr. Tahura, for kind words.
Thank you, ma'am.
Good afternoon, everyone. We have our first speaker, Professor Dr. Russell D'Souza. Can I have the CV? Yeah. So, sir is head and chair, Asia Pacific Division, UNESCO chair in bioethics, director of education, international program, executive director and dean, professor of organizational psychological medicine, International Institute of Organizational psychological medicine. So he has got so many degrees to his credit. So we are indeed lucky to have a speaker like him in this conference. I welcome you, sir. You can start with the presentation. We have 30 minutes for the presentation.
Is Dr. Russell D'Souza with us?
I can't see.
It seems he's not present with us right now. He has sent a video of his presentation since he could not be able to join us personally via Zoom. So, ma'am, could you just please wait for a few minutes before we start displaying the presentation which he has sent to us? We'll just take a few moments, ma'am.
Okay.
There has been a slight change in schedule. Yes. There has been a slight change in schedule. We will be having esteemed Dr. Jyoti Shetty speak to us first because of our technical glitch in presenting Dr. Russell D'Souza's video. Ma'am.
Okay. Welcome, Dr. Jyoti Shetty, madam. Nice to see you. I think Dr. Archana will introduce you.
Good afternoon, all.
I think you have to unmute.
Yes, I have unmuted. Hello, Dr. Jyoti Shetty has completed her MD Psychiatry from BJ Medical College, Pune. She is currently working at Department of Psychiatry of Bharati Vidyapeeth, Pune. She is holding a post of professor and head of Department of Psychiatry at Bharati Hospital and Research Center. She is convener of Child Psychiatry Subcommittee of IPS. She has been convener of Child Psychiatry Subcommittee of IPS in 2015-16. Convener of Forensic Psychiatry and Law Subspecialty of Indian Psychiatry Society. She is president of IPS Pune branch in 2016-17. She is recently nominated as a co-chairperson for perinatal psychiatry task force. She has 21 publications and her area of interest is child psychiatry and forensic psychiatry. We are happy to have you here, Jyoti.
Thank you. Thank you very much. Would the organizers start the PPT? Because
Yes,
I have already shared it.
Yes, you can start.
Yes, ma'am. We are just displaying it, ma'am.
At the outset, I would like to thank the organizing committee, Dr. Saldana, Dr. Javdekar, Dr. Surya Prakash Chaudhary for inviting me for this talk. And it's been quite an exhaustive 3 days, and it's been very successful considering it's been a completely virtual web conference. Thank you very much again. Is it possible to share this PPT?
Yes, ma'am, we are. We just have some Wi-Fi disturbance, ma'am. So we're just going to do it.
Okay.
Yes, ma'am, it's begun.
Okay, fine. Can you make it full screen? Yeah, thank you. Am I audible?
Yes, ma'am, completely.
Okay, fine. So this talk is obviously not really in keeping with the theme of this conference, but then it has been something that I think we all need to be aware of, which is a minority community, that is LGBTQ. Today's talk, I will focus on LGBTQ and law. Next slide, please. Just to give an introduction on what we look at when we talk about LGBTQ, which is the lesbian, gay, bisexual, transsexual community. So when we talk about LGBTQ, we understand sex as biological sex, as in what a person is born as in a biological sense. Gender, as in his gender predisposition to how he looks at himself or she looks at himself. It's also seen as a cultural concept. Identity being how that person views her desires, her or his identity, expression in the way they dress, orientation being either homosexual orientation or heteronormative or heterosexual orientation. Next slide, please. So when we look at terminology, I think all of us are familiar now with this terminology because it has been in the news for such a long time now. Lesbian, gay, bisexual, transgender, transsexual, queer, intersex, and asexual. Most members of the community look at themselves as non-binary, while I think for us, heteronormative individuals, we have always been brought up to look at gender and identity and sex as a binary phenomenon, mainly being male and female. Next, please. But in view of the community's needs and in view of the discrimination that has been faced by them as a minority community, there is a need, and especially for us mental health professionals, to reduce the ignorance, prejudice, discrimination, and the insensitivity, and also to help create, along with them, ally with them, to create a safe zone which helps them to express their sexual orientation safely, express their gender identity safely, and their gender expression in a very safe and secure atmosphere. Next slide. Because of the problems that they face, now this starts even from home. There could be harassment at home. For example, if a child is seen as a very effeminate child, effeminate boy, there could be sexual abuse, ragging in schools and colleges, sexual harassment and abuse by society at large, discriminatory healthcare facilities too. I think even when they try to seek any sort of help for any innocuous problem, medical problem, they could be discriminated against, especially transgenders, lack of inclusive spaces for jobs, and especially for transgenders, it is lack of sanitary arrangements in public buildings. This also includes hospitals, lack of subsidies for housing and other social support needs, and discrimination from access to public spaces. I think this is something like, you see a transgender at a signal, there's an instinctive tendency to, sort of wind up your windows, not wanting to sit and interact with them or communicate with them or engage with them in any which way. Next slide, please. Workplace discrimination, as I said, and this is not only about transgenders, even about LGBT community, which looks a little different, probably dresses differently, would be seen to be discriminated against. There's an almost a community internalized homophobia that is there. There could be a lot of judgment and disapproval from the family members and judgment within the LGBT community too. And this is especially so when we talk about gays and lesbians being a little bit judgmental about transgenders, gender queer individuals like gender fluid individuals. Denial of basic human rights and needs, and I have given some of the references there. Next slide. Of course, the mental health issues are several. In fact, I think a few years back, the PCNA, the Psychiatric Clinics of North America, had come out with a nice volume on transgender health and mental health issues. There's a lot of depression, anxiety, suicidal attempts, suicide in fact, which is 8 times higher than the norm, PTSD, post-traumatic stress disorder, substance use disorders. And it's a combination of all these factors which actually make them much more isolated and alienated with no access to healthcare facilities also. So they basically get affected on both sides. They cannot seek help, and they do have a lot of needs compared to the community and the age that they come from. Next slide. So mental health services, when we talk about, what we should be doing, we can do the assessment, counseling, aiding in coming out, family education and counseling, especially doing the assessment in gender dysphoria because the psychiatric or mental health professionals assessment is required. Coming into counseling when there is any sort of intersex case, especially liaising with pediatric surgery, pediatric endocrinology, and having a counseling session with the family, with the individual, especially an older
Ma'am, we are unable to hear you.
Hello. Next slide, please.
Yes, ma'am. Now we can hear you.
Yeah, I got logged out, I think, in between.
Oh,
Right.
okay, ma'am.
Just to sit and give a little bit of information on gender dysphoria, then I will go to the laws which are relevant to this community. Gender dysphoria is something I thought I will focus because it's something that we are doing in our LGBTQ clinic on a routine basis. Just to give us a little bit of statistics, 1 in 11,000 biological male is a trans woman, 1 in 30,000 biological female is a trans man. Of course, the current care as far as SOP is concerned with regards to intervention in gender dysphoria is the current version 7 of the WPATH, which is the World Professional Association for Transgender Health. The IPATH, which is the Indian Professional Association for Transgender Health, also follows the same SOP. The Association for Transgender Health in India is a banner for the IPATH. I think you can look up as far as online the SOPs are concerned. Next slide, please. This is just to go on the classification according to ICD-10 and DSM-5. Probably I will not go directly into the details, but in ICD-10 it comes under the parent category of gender identity disorder, diagnosis transsexualism. There should be evidence of distress and dysfunction, and it should be over 2 years. And in DSM-5, the parent category is gender dysphoria. The distress has to be there, obviously. Of course, the duration criteria is a little less, it's 6 months. There obviously has to be a marked incongruence between expressed gender, experienced gender, and the primary, secondary sexual characteristics, a strong desire to get rid of these characteristics, to be treated as the other gender, also a desire for the characteristics of the other gender, strong desire to be the other gender. And this all will be along with a lot of expressed, in terms of behavior, attitude, dressing, etc. So this is something that is common even in ICD-10. And of course, additionally, I think we have all come across gender dysphoria cases where, for example, a trans man may probably have a lot of distress, especially when they have menstrual cycles, and they don't wish to actually, they start bending up their breasts when they start hitting puberty. So these are some of the additional features that we may see. Next slide, please. ICD-11, of course, which of course we'll start using only in 2023, has replaced ICD-10's transsexualism and gender identity disorder of children with gender incongruence of adolescence and adulthood, and gender incongruence of childhood, respectively. Gender incongruence is moved out of the mental and behavior disorder chapter into the new conditions related to sexual health. So it is out of basically the purview of psychiatry, so to speak. This reflects the evidence that trans-related and gender-diverse identities are not conditions of mental health, and classifying them as such can cause enormous stigma. Here, I would just like to add, I think assessment by mental health professionals, irrespective of their classificatory changes, is still essential. This is for the support, for the diagnosis, and also for giving some sort of liaising that will help a gender identity disorder individual to go ahead with their gender affirming interventions. Next slide, please. So when we just, this medical certification, I thought I'll just go over it a little bit because it is also important when we come to the laws. Medical certification for gender dysphoria, obviously it should be on a letterhead of the mental health professionals with the date, specified need for the certificate, the patient's name, ID, date of birth, ideally speaking, because that will be there in the ID, specified duration of care that the person, mental health professional, has seen him, diagnosis, treatment, if any, of any comorbid disorders, capability of understanding, making informed decisions, communicating choice for treatment, psychiatric fitness for treatment, and statement of issuance of certificate only on request. So then you should mention that the patient has requested, so hence we are giving it. Next slide, please. Additionally, I would like to add, please do not issue such a certificate for any individual below 18 years. Do not issue on the first visit. Do not issue if you're unsure of the diagnosis. Please do not issue if the patient is inconsistent or doubtful or seems to be having any comorbid major psychiatric disorder unless you really evaluate and treat that. Always try to get the support of the family. Next slide, please. Now, movement towards inclusion, as far as all the laws are concerned, has started some time back. The WPA position statement in March 2016, and of course, the IPS came out with the position statement in July of 2018. The repeal of Section 377 of the Indian Penal Code on 6th of September 2018 was a landmark date. This was about more than 2 years ago, and that has actually helped in a lot of individuals from the community seeking help and going for some sort of intervention. The IPS task force also was instituted in 2016 and reconstituted in 2018. The NALSA judgment was something that predated this, and it brought about a huge change as far as transgenders were concerned in 2014. Of course, the Transgender Protection of Rights Act came out in November 2019. And of course, the Mental Health Care Act of 2017 also prohibits discrimination of any individual, regardless of sexual orientation. Next slide, please. So just to go back to how we have had the repeal of 377 section of the IPC. Now, Chapter 16, Section 377 of the IPC 1861, which was modeled on the Bagri Act 1533, criminalized sexual activity against the order of nature. Now, this was because of the British period. 2001, there was the Lucknow incidents where actually the police rounded up individuals in a garden and filed a suit on 377, and then this provoked the NAS Foundation suit versus NCT Delhi, where they actually fought for repealing 377, citing that basic fundamental rights enshrined in the Article 14, 15, 19, and 21 of the Indian Constitution was something that was actually controverted by 377. The 2009 Delhi High Court ruling was in their favor. But again, in 2013, Suresh Kaushal actually filed a suit against NAS Foundation. And 2013, SC overruled the Delhi High Court verdict, saying that the repeal should be left to the parliament, which was again, going back. In fact, they said that the Kaushal judgment said that probably the LGBT community is so minor that it is not required that we make such a huge change as far as the IPC section is concerned. Next slide, please. 2016, there was filing of the curative petitions by several people, including the NAS Foundation. It was 2017 actually, which is actually the Aadhaar judgment, which paved the way for repeal of 377. This was the Puttaswamy versus Union of India, where the right to privacy was something that was given, and this paved the way for the repeal of 377 because it was about privacy of any sort of activity in the privacy of your home obviously should not come into a criminal proceeding. The 6th September 2018, the Supreme Court decriminalized same-sex intercourse, reading down 377 to exclude adult consensual homosexual activity. It also criticized the Kaushal judgment, said sexual orientation is an inherent part of the self-identity. Next slide, please. These are the statements by the justices who were part of the 5-bench commission. So Justice Indu Malhotra, while reading her 50-page verdict, said that history owes an apology to the members of this community and their families for the delay in providing redressal for the ignominy and the ostracism that they have suffered through the centuries. Chief Justice Deepak Mishra, criminalizing carnal intercourse is irrational, arbitrary, and manifestly unconstitutional. Justice Chandrachud said that it is difficult to right a wrong by history, but we can set the course for the future. This case involves much more than decriminalizing homosexuality. It is about people wanting to live with dignity. So this was actually the 377 timeline. Next slide, please. Going to the NALSA judgment, which was actually a little earlier, 2014, which is basically the National Legal Services Authority. They had filed a suit to recognize transgenders as a third gender, and the SC ruled in their favor, needing education, health services, employment. And this was a big relief to the transgender community. They could change gender without surgery. They were recognized as backwards socially and economically. Next slide, please. Transgender Protection of Rights Act came out in November 2019. It defines trans person as someone whose gender doesn't match assigned biological sex at birth, prohibits discrimination, allows self-perception of gender identity, but mandates legal recognition on the basis of certificate from the district magistrate. So if they have to go for any sort of gender reassignment or affirmation intervention, they would have to get a certificate from the DM to say that they have gender dysphoria and they're either trans men or trans women. But however, it also lacks because it criminalizes begging with no provision for reservations in education or employment. And this has been the bugbear of most of the people in the community, that they say that there's no reservation for education or employment. So people will be forced to do one or the other and then be penalized. Next slide, please. Coming to the family laws. Now, why I wanted to cover some of the family laws was for this reason, that once 377 went, the community has been fighting for a lot of other laws also, maybe at individual levels. In fact, there's a couple who, one is a psychiatrist, I think, and one is a psychologist who have been in partnership, female same-sex couple. They have been fighting to get married. So when we look at our laws, there are two types of laws. One is secular, one is personal. Secular, obviously, they say is applicable to everyone. But this year, we have to understand that it's not applicable to the LGBTQ community in marriage, separation, divorce, or inheritance issues. And personal laws are different. It could be the Hindu Marriage Act, which actually governs Hindus, Sikhs, Buddhists, and Jains. Muslims have the Sharia. The Indian Christian Marriage Act of 1972 for the Christians. Parsis have the Marriage and Divorce Act 1936. Here we have to remember that a lot of these, the religious communities are against LGBTQ on principle also. So they would not be looking at changing their laws anytime soon. So that is one thing. Marriage legislation is seen as necessary if you look at legal partnership, inheritance, adoption, for example. So then all, quite a few members from the community, the LGBT community, minority community do want to settle down, be married to their partners, and if not behave like heteronormative individuals, but at least have a family of their own. So unfortunately, our current laws do not allow that. Next, please. So they do say that, people can go in for the Special Marriage Act, but sodomy is a ground for divorce. And this needs to be redefined in the Act, especially since the repeal of 377. Surrogacy, the regulation bill of 2020, it was progressive in stopping commercial surrogacy, but then it discriminates against LGBTQ communities. So they can't go in for any sort of surrogacy, having a child through surrogacy. Then, of course, adoption laws are also a little factored against them. They require a male and female in a stable relationship for about more than 2 years. So that is another problem. Not to say that, people have not gone in for having children by surrogacy or even adopted, but these are some of the pitfalls of our laws at present. And of course, the inheritance laws, which do not really specify specifically about the LGBTQ community. Next, please. Sexual harassment of the women at workplace. I think Dr. Samiksha Sahu had done a wonderful job yesterday when he spoke at length on this. So I won't go into the details, but then what has been seen is that the LGBT, it's a POSH Act. LGBTQ workplace survey in 2016 showed 40% had harassment of various kinds, especially sexual. Transgenders seem to be the most affected, especially when you have various laws like anti-begging, immoral trafficking act also being brought in. So this is one area that obviously needs to be tweaked. The armed forces is another area that needs to be LGBTQ inclusive. We won't go into much detail of that. Next slide, please. So in conclusion, there is a need for awareness, education, and inclusiveness in all spaces for the LGBTQ community. Medical education in the ambit of the recently introduced CBNE, or the Competence-Based Medical Education Program, has made this part of the undergraduate medical education. So then we do have, as part of the ADCOM module, a lot of sensitizing lectures on how to deal with being inclusive, about cultural competency, about diversity, about inclusiveness as part of an undergraduate program. It starts with the foundation course. So, but then unfortunately, a lot of other academic areas have not been actually tapped. They need to be sensitized about how to deal with this minority community. Laws need to now be reviewed to be gender neutral and inclusive. And this is something I think gender neutral probably should be highlighted, because all our laws need to be gender neutral to a large extent, especially things like the POSH Act. And next slide, please. This is few of my references which I had mentioned, and as I said, the various acts as per government notification gazettes. Thank you very much for a patient listening.
It was a presentation, very lucid, as usual, and interesting. I hope all the residents will definitely benefit from your talk. Are there any questions? Actually, I can't see in the chat box. Dr. Archana wants to comment, ask any question.
It was a very nice presentation, Jyoti. It is a very unusual topic also.
Thank you very much.
I have one question.
I have to also add that Mr. Bindu Mahavadar Khere, with whom we have an MOU, was also responsible for tweaking it a little bit because he had his own inputs. Yeah, please go ahead.
Are there any laws regarding the gender of child you can adopt for these people?
No, there are no laws. I think there is, the common laws are that, see, as far as adoption is concerned, unfortunately, they're supposed to be heteronormative individuals in terms of a male and a female being in a relationship, preferably married, obviously, for more than 2 years. And the laws are usually about, that if they have a boy child, then they cannot have another one, for example. Okay. Apart from that, I think though we have individuals who do adopt, as such, I am not aware of anything that where LGBTQ individuals, specifically, for example, males, should not adopt a boy child. There's another area which I didn't touch upon, so I'll just mention it if you have a little bit of time. It's about intersex. Actually, in the space of gender dysphoria, intersex. We just had a discussion last week in our hospital, actually, with the pediatric surgeon and the pediatric endocrinologist. They do a lot of these intersex surgeries. Of course, Tamil Nadu is the only state which actually has come out with a directive where they say that intersex children should not be intervened in terms of surgery, intervened till the age of maturity, till they make a decision about which sex which biological sex and gender they prefer. But unfortunately, because of family pressures or whatever, it usually happens in a lot of hospitals where, it is seen that, for example, it's seen that making the child a female is much more easy because surgically it's easier. Or it is there's parental pressure for the boy. So even if it's a child with an ambiguous genitalia, would probably operate, and there could be a clitoral enlargement, but then the thing is the child is brought up as a boy. So, but then without taking into consideration that later on the child could have mental health issues, probably dysphoria because of that, and even probably sexual orientation issue, could be something different that is not addressed. Unfortunately, I think in a lot of places there is no good group multidisciplinary activity in terms of counseling for such issues. Yeah.
Thank you, Jyoti. On behalf of Archana, she has just gone out.
Okay.
I would like to thank you for your wonderful presentation, and very nice to see you present this. You are an expert. I think you must curtail your lot of duties, I think, now, and concentrate on yourself.
Thank you. Thank you, sir.
Now we will have the last speaker who has sent his video presentation. May I request the MC to please go ahead?
Yes, sir. So we're just starting the video, sir.
Conference. I am Professor D'Souza, and I'm talking to you from Australia, where I'm normally based in Melbourne, but today I'm up in called Hotham. Now, I'm delighted to speak to you today to present a very important aspect, that is the effects, the COVID, its effects on the psychological health of healthcare force and its impact on function. I want to acknowledge Brigadier Raju and thank him for inviting me to present to you today. As you know, I'm the Dean of the International Institute of Organizational Psychological Medicine. This is the branch of psychological medicine that looks at the workforce. The workforce, importantly, productivity in the workforce. And indeed, the healthcare workforce in the pandemic is crucial. And we're going to hear something about what we've learned in the last year or so, having dealt with the pandemic. The emergence of this COVID, or the coronavirus, and its resulting global pandemic have significantly taxed the capabilities of healthcare systems around the world. The long-term psychological impacts of COVID-19 pandemic, in particular the frontline healthcare workforce, has yet to be fully understood. But attention to the staff's psychological and mental health and well-being and their function is utterly crucial and critical to crisis management in the current pandemic. Now, infectious disease makes it more complex. They pose a unique challenge to the healthcare workers compared with other disasters, natural disasters. It arises both from the nature of the disease and from the need to protect themselves from infection, with measures such as quarantine and personal protective equipment. And the undesirable of psychological well-being among the frontline healthcare workers have been already documented, with a lot of literature and data being submitted. And significantly, depression, anxiety, substance abuse are seen. Importantly, we are also seeing some new areas: distress and moral injury and embitterment. So let's look at that. Now, the mental health outcomes, if you look at some of the studies, look at this Italian study. While we have anxiety, depression, insomnia, we see distress, which is 49.38%. Like, look at a Chinese study. Again, we have all the anxiety, depression, but distress comes out as 69.1%. And then we look at our very own Indian study by Gupta, and this looks at again, perceived distress is significantly higher, and there's some amount of post-traumatic disorders, but here we see the nurses are the most common population, followed by doctors. Cross-sectional study looking at, from China, looking at the diagnosis, we see depression, anxiety, insomnia, as you would expect, but again we see distress as significantly higher. Now let's look at this area called post-traumatic embitterment. This again, when stress makes you bitter. There's a paper written by Embitterment Disorder and COVID by Lindemann from Berlin University. And we see again bitterness arises from situations or life events that are perceived as unjust or a threat to a person's basic beliefs. Its emotional quality is a mixture of anger and hopelessness. The person puts the blame on external situations and has little hope for change. And post-traumatic embitterment disorder applies to a person receiving or experiencing, witnessing, or even directly being confronted with a traumatic event or events, such as a major loss of a significant other, a serious illness, disability, physical or emotional abuse, leading to chronic feelings of embitterment, anger, resentment, irritability or rage, and obsessiveness sometimes, but a compelling desire for retribution. So we talk about moral injury. This is some area that we have not seen before. It appeared to be more in with return from the work, we're returning from the army or from the war. But we're beginning to see this. And here's some evidence from data by Williamson and July et al. Moral injury in times of COVID by Williams in May, moral injury in Chinese health professionals, again Wang, and moral injury among healthcare providers during the pandemic. And so we have a number of these studies suggesting the emergence of moral injury as in the workforce. So what is this moral injury? I'm going to ask you to imagine being a healthcare provider required to triage COVID-19 patients. You are inside a crowded emergency room, deciding which of the two patients you will get your emergency room's only remaining ventilator. Although you understand the situation requires you to give the ventilator to the person with the largest or the highest odds of survival, indeed you were not trained to make these kind of decisions. You've always had the resources to treat all patients. And in this scenario, both the patients die, despite one getting the ventilator. Now, this moves on, and you wonder whether you made the wrong decision. With a ventilator, you're wrecked with guilt, replaying the scenario over and over, analyzing how different choices might have created different outcomes. Your distress becomes overwhelming. So you bury yourself, but the pain follows you home. You avoid genuine conversation with your family and peers to distract yourself at the extreme expense of routines that were once meaningful. You even tell yourself that you followed protocol, did the best you could, and yet you feel you violated your moral values. This scenario is precisely the context in which moral injury developed. Although little is known about moral injury in the non-military population, COVID-19 pandemic has made it clear that moral injury's relevance indeed extends far beyond the battlefield. It is natural that in response to these potentially morally injurious events, people experiencing moral emotions like guilt, shame, disgust, anger, and contempt, as well as cognition related to blaming themselves or others. And moral injury occurs when the painful moral emotions and cognitions are avoided or suppressed. And what happens is it results in greater suffering, the person's ability to function effectively. And what happens, it leads to social, psychological, and even spiritual suffering, often present in moral injury, as difficulties in meaningfully engaging in valued areas of life. So, what is the link between moral distress and moral injury? I showed you some data of moral distress. Moral distress and moral injury may appear to be similar, since both are related to moral suffering. However, what appears to be mainly distinguishing moral injury from moral distress is that moral injury are associated with death-related incidents. So, on the other hand, moral distress refers to one having to deal with moral dilemmas, or what we call moral disequilibrium, experienced by multiple mundane incidents that frontline healthcare professionals frequently in their line of duty. To this end, moral injury, for instance, may be experienced with an intense sense of feelings of guilt, shame, and frustration that a healthcare worker may experience, often to death-related incidents. On the other hand, healthcare workers may experience multiple incidents that may cause moral distress. Over time, guilt, shame, other feelings accumulate due to multiple morally distressed situations causing incidents in the line of duty. And of course, we see moral distress and moral injury are cumulatively intertwined. And what eventually happens is it leads towards traumatization, compassion fatigue, post-traumatic stress, so forth. And then what about moral distress and stress? We're learning a lot about this. Multiple experience of moral distress can result in moral residue, a buildup of unresolved conflicts within the clinician. And this might end up have what's called tolerable stress. So tolerable stress responses are more severe, frequent, and sustained with moral distress. And the body responds to a greater degree to these with biochemical responses and have the potential to negatively affect brain architecture. Now, what we know from tolerable stress, we look at chronic moral distress, moral injury, and toxic stress. Moral distress and moral injury are intertwined and may lead healthcare workers to experience of compassion fatigue, continuous experience of multiple critical incidents that lead to experience of moral distress, moral injury, and chronic toxic stress. Toxic stress results in prolonged activation of the stress response with a failure of the body to recover fully. And this affects the neuroendocrine immune network, and the response leads to what may be a prolonged abnormal cortisol response. The result of this is immune dysregulation, including persistent inflammatory state. And the toxic stress response is believed now to play a role in pathophysiology of depressive disorders, behavioral dysregulation, PT, post-traumatic stress disorder, and even in psychosis. So, challenges to morals because of competing obligations. We see that change practices due to COVID-19 pandemic will inevitably result in tension. Individuals' clinical ethics versus public health ethics. Best medical practice versus resource scarcity. Expert practice versus practicing on the edge or beyond one's competencies. These tensions generate moral dilemmas in their workforce every day, in their workplace, with a high likelihood of causing moral distress, as you've seen from the data. Moral distress occurs when external or internal constraints preclude the performance of an ethically appropriate choice of action. And multiple experiences of moral distress can result in moral residue or a buildup of unresolved conflicts within the clinician that makes the future scenarios that create moral stress less tolerable. What we know about presenteeism? Now we look at the workforce. Presenteeism and occupational acquisition of COVID-19, published in the Australian Journal of Medicine. Again, we see COVID-19's presenteeism in medicine. Professor Peter Colligan of the Australian National University canvassed the view of more than 5 nations in the world, and 9.2% of healthcare workforce went to work with minor psychological issues, anxiety, distress symptoms, including fatigue and reduced appetite. This led, of course, to low morale, feeling obliged to show up to work when not feeling 100%. This often manifests itself and in a demotivated employees. This is essentially the case when employees are battling through illness, injury, and other struggles during their work time. And what this leads to, as we've seen in Peter Colligan's work, increasing errors and mistakes, sloppy work. So presenteeism essentially means that when the employees are at work in body, they are not necessarily there in mind. When the mind is impacted, errors creep into work. And in the medical workforce, in the intensive care, errors are unacceptable. So what do? We need to cultivate moral resilience. How do we do that? Fostering self-awareness, developing a self-regulatory capacity, developing ethical competence, speak up with clarity and confidence, find meaning in the midst of despair, engage with others, participate in transformational learning, contribute to a culture of ethical practice. Managing moral distress and moral injury, we should promote early intervention. We should be looking at developing tailored interventions for these populations, and existing treatments of moral injury, such as acceptance and commitment
We are extremely thankful to respected Dr. Sharmishta Deshpande and Dr. Archana Javdekar for gracing us with their kind presence and for efficiently conducting our last session for the day. Also, we are indebted to Dr. Jyoti Shetty and Dr. Russell D'Souza for taking out time from their busy schedules to share their knowledge with all of us on extremely relevant topics in today's time and age. With this, we have successfully arrived at the closure of the last session of the 18th Annual National Conference of Association of Industrial Psychiatry of India. We shall now proceed to our valedictory function, which will be... in 10 minutes, which will be graciously chaired by respected Dr. Colonel Suprakash Chaudhary. Thank you so much.
Please stay on. Please stay on.
Please stay with us.
I take this opportunity to welcome Professor Dr. Sridhar Sharma to the valedictory function. Sir, please hold on for a few minutes. We will start the valedictory function very soon. Sir, kindly unmute yourself, sir. Sir, we'll start the valedictory function in 5 minutes. Just hold on.
Okay,
Thank you for
thank you.
joining the function, sir. हाँ सर हाँ ये ओरल पेपर का बाकी उसको भेज दिया मैंने सर वो सब भेज दिया हाँ अग्रवाल को अग्रवाल ज्वाइन नहीं किया यार
Agarwal joined.
हाँ ज्वाइन हो गया
I'm here,
Welcome.
sir. I'm here.
हाँ हाँ
Thank you.
Welcome, Dr. Agarwal. We'll start in few
Thank
minutes.
you very
Just
much.
hold on.
Thank you. Good afternoon to everyone. ये क्या कर दिया? दोनों नाम
काम है सर के अंदर जाना है वो दूसरा टैक्सी उधर खड़ा है ये जाए जाओ
Sir, first I will award you. After welcoming everyone, we'll start with awards. After welcoming everyone. Then we can.
He will first go and he will ask.
अभी बातें करो बंद करो. करना. You are on. नमस्कार सर. एस डी शर्मा साहब. प्रणाम. आवाज आ रही है शर्मा साहब? एस डी शर्मा साहब.
हाँ आ रही है अब.
डॉक्टर अग्रवाल हियर. Good afternoon.
Yes, yes, I can.
Sir.
Good afternoon. How are you?
All well.
So you are talking from Kota or from virtual?
Yeah, from Kota, right from Kota, near to you.
No, I am in South Tamil Nadu, Coimbatore today.
Acha, okay. I was thinking you are in Delhi or.
No, not in Delhi.
No.
The COVID brought me to Tamil Nadu.
Okay, due to COVID?
No, COVID, my son is here.
Okay,
so,
in Tamil Nadu. Where?
Tamil Nadu. Coimbatore.
Coimbatore. Okay. I think soon conference will be there, Coimbatore, huh? Visakhapatnam, somewhere.
No, Coimbatore is near Ooty and.
Ooty, huh? Near Ooty.
But it's a good town for a conference. I'll be in Delhi after about 10 days.
10 days. Health is good? Previously, he was in the Ramanotloya, your son.
My son is in Ramana. Yes. Yes. Good evening, everyone.
Good evening, sir.
Thank you. We now come to the end of this conference.
Yeah.
Moving on to the valedictory function.
Okay.
This was our first experience with online conference, and there it is a learning phase. But I think we have achieved fairly good results. Of course, it will all depend on the opinion of the audience. At the outset, I will request Dr. M.L. Agarwal to announce the awards.
Okay. First of all, I would like to thank organizing committee to give me this job, and Dr. Sridhar Sharma, SD Sharma sir, and Brigadier MSVK Raju to include 2 more awards in the basket of the industrial psychiatry. I thanks them and welcome them here. So I start from the awards. Gayatri Gopal Award. This was the very old first award of the association. Gayatri Gopal Award was started by Gopal Kar. So Brigadier MSVK Raju, President, is selected. This is selected by the Board of Directors, and Colonel Jyoti Prakash. Both are getting this award. Both, especially Raju, deserves for this award. Much done for the industrial psychiatry. This award goes to the person those work for the uplifting of the industrial psychiatry society. So both persons are deserving persons. We congratulate to MSVK Raju and Jyoti Prakash. Next award is Aruna Madan Award for the health promotion industry by community approach to decrease the social stigma in the industry. So that award started by me in the name of my wife, and Dr. Mrs. Kalpana Srivastava was won this award. She has given the good presentation yesterday about the community approach of her, especially for positive mental health. Very important award, new award this year by our president, immediate past president. So I can speak immediate past president today, but he worked during his presidency. Professor Alka Pawar Merrill Award on Family Mental Health in Industry. Dr. Ajit Avasti from the Chandigarh is selected for this award. Ajit Avasti from the Chandigarh, past president of Indian Psychiatric Society. Very important award started by our respected SD Sharma Sahab. This year, Professor Sridhar Sharma Award of Psychiatry Teacher in Education. This is the special award. This award won by the Brigadier Retired P.K. Chakravarti. I remember Ranchi conference organized by him, wonderful conference organized him. So he is already working so much for the society, and he won this award. Good teacher. Next award, Shanti Niketan Mental Health Award, won by the Dr. Srela Mujawar. Title of the paper was a community-based study of prevalence and functional study of the major depressive disorder patient in industrial area. Is the winner of this award, Shanti Niketan Mental Health Award. Next award is Dr. Pratibha Kumar Award. This award won by the Dr. India Ram Subba Reddy, or past president of AIPI Psychiatric Morbidity. Paper was on psychiatric morbidity in absenteeism in industry. So this award goes to the Dr. Reddy. Next award is GC Boral Award. GC Boral Award is won by the Dr. Archana Javadekar, topic was a comparative study, depression, anxiety, stress, and sleep disorders, and in general population and doctors in developing countries. This GC Boral Award won by the Dr. Archana Javadekar. Lakshmi Shanti Award. This award by Dr. Shelvija Avinash, Life Fellow, Clinical Care Relation of Regional-Based mental volume in schizophrenia, structural magnetic resolution imaging study. Very good start of this important study was done by Dr. Shelja Avinash. Good presentation was there. Best Poster Award by judge and judges sent me the best postal award goes to Lieutenant Colonel Amresh Dubey. His poster was on risk factor for the postpartum depression. Second poster award goes to Captain Yugal Mansingh. Internal gaming disorders was the topic. Third goes to Dr. Love Surti, Dr. Tahurura, Dr. Sadaf Aziz. Title was the Police Substance Abuse in Adolescents. These were the three posters were selected for the award. Best paper by PG students. I have not received so far information, though I request Dr. Chaudhary to name the winner.
Dr. Agarwal?
Yeah.
Here we had a large number. We had almost or more than 60 posters, and we had nearly 50 papers.
Yeah.
So the poster awards, of course, has been announced by Dr. Agarwal. The paper awards we could not send to him because the paper presentation finished only now.
Okay.
The judges have given 3 best paper awards and then 2 consolation awards.
Yeah.
Best paper awards are Dr. Madhusudan Gugilla, Perceived Impact of COVID-19 Lockdown on Medical Education by Final Year Undergraduate Medical Students.
Okay.
Second paper is Dr. Madhura, Dr. Supriya and Dr. Nishta, Association of Childhood Psychological Trauma with Disordered Eating Behavior and Suicidal Ideation in Medical Students. And then Dr. Namita Sharma, a comparative safety and efficacy of Tibolone and Escitalopram in postmenopausal women. The consolation prizes are Dr. Pooja, her topic is burnout and resilience in doctors. An original work, this is a comparative study between preclinical and clinical departments during the COVID-19 pandemic. The other is Dr. Soumya A.V., the impact of COVID-19 on OCD symptoms, a case series. So these are the awards. I thank Dr. Agarwal for taking a lot of efforts. In fact, he was...
Okay, I will include in the record, I will include... Okay, in the end, I will like to congratulate every winner, especially very thankful to Brigadier Raju and Dr. Chaudhary, Dr. Saldana, and all members of the organizing committee to give me this opportunity and free hand to select all the awards. Thank you very much to everyone. I continue next.
As I was just mentioning, we are very grateful to Dr. Agarwal because without his help, we could not have done this massive job of sifting through all the papers. He has taken pains of reading and marking all the award papers which are for presentation. And so we have to only tell the judges to write the marks for presentation. Thank you very much, Dr.
Welcome, sir. Welcome.
Now, we are extremely lucky to have among us Dr. Sridhar Sarma, a doyen of psychiatry in India, and of course, known to everyone in this audience. I welcome you, sir, and I request you to say a few words.
Am I audible?
Yes, sir. Yes, sir. Yes, sir.
Yes. At the outset, I regret that I am not physically present during the conference because of the COVID problem. But I would like to congratulate Brigadier Chakravarti for getting this first award. I knew him when he was in the army and later when he was the director of the Rinpas in Ranchi. And I used to visit very frequently. His contribution is vast and unique, both within the army, in the civil, in Ranchi, and also in outside Nepal and Malaysia. He is the most deserving candidate, and he is such a humble and a knowledgeable person that he is the most deserving person, and I congratulate him. I can't congratulate and meet personally and physically, but I hope he would accept, and later when we meet, I will personally congratulate him again. Thank you. Thank you.
Thank you, sir. Thank you, sir.
Thank you very much.
Actually,
Brigadier Raju will say something.
Here,
About second award, Brigadier Raju will say something.
Brigadier Raju.
Sir, now I request Brigadier Saldana to say a few words.
Sir, I bow my head and respect you for gracing this occasion, Professor Sridhar Sharma sir, and be present here for the valedictory. We would have been very happy and honored if you were physically present here, but I know because of this COVID, we are unable to do so, and we had to do virtual 3 days of conference from 9:30 to 5, and we have just finished it. And all the sessions there were about 30 odd presentations by so many renowned psychiatrists from across the world. That is United States, United Kingdom, Australia, and India, and Canada. I must not forget Canada. And all were represented and logged in by not less than 250 delegates on each day. There were 274 registrations for this conference. There were more than 54 papers, original papers being read, and there were 60 poster presentations. And it was a Herculean task for us to sift through and declare the winners, and they were of high quality. With the so much of IT technique involved in all these papers, gone are the days that we can just hear and then judge the papers. It is not so. With the statistics and so many things are involved, it is very difficult to judge the papers. And I congratulate all the winners, those who have worked day and night, and with their hard work, they have achieved this present state. I should not forget to thank my team. In the last 3 days, they were round the clock, and not even a single glitch was there which they could not handle. And there were 6 rooms, and there were, I don't know how many, countless computers running simultaneously. I congratulate and thank Dr. Jaideep Patil for coordinating the event, and Dr. Taura for being an MC, who is a first-year resident. Somebody asked me if you have given this conference to event management. That was the impression everybody got. And event managers are here only in my department. And thank you everyone. And I should not forget to thank Brigadier Raju for his constant support. And I don't know how many times he has made his trip to Dr. D.Y. Patil from his house. It is more than about 30 kilometers. And he has spent his own money and come every time. And I thank him for everything. And he has given the impetus for this conference, which I can never forget. And I thank Brigadier Chakravarti and General Wandhya, who had come in between. And they also were a source of inspiration to all of us. And I congratulate Dr. Suprakash Chaudhary. He is an eminent psychiatrist, and I think he is a deserving president. I think he will take this industrial association with leaps and bounds. And
I'm sure, pretty sure that our journal will reach greater heights. Thank you very much, and thank you one and all. I'll request Dr. M.S. Raju to say a few words.
First of all, I would like to thank you for being here with us today. So we wish you very well that you would be here to hand over the first ever award instituted in your name with your hand. Unfortunately, the COVID had done the damage in that way, but next year we do hope that you will be with us and hand over the award which carries your name by your hand. And whenever you are back in Delhi, sir, I will come and pay my regards and respect to you. Thank you very much for joining, sir. Thank you.
Okay.
Usually we have the award presentation ceremony where all the awards can be given, but unfortunately this time it was an online presentation. But we are lucky that Dr. Brigadier P.K. Chakravarti is present. So I have the honor and privilege of handing over the award to him.
Is he? He's on the screen. Is he on the screen?
Yeah. Unfortunately, due to the COVID situation, the other winner, Dr. Ajit Awasthi, is not present. So, Dr. Tahura can collect it on her behalf. Dr. Archana can collect it on his behalf. Are you, sir? Yeah.
Yeah.
Thank you. Thank you. Now, I will request Dr. Jaydeep Patil to propose a vote of thanks.
Yes,
sorry, I forgot. We would like to hear the impressions of various delegates about their experience. We can start off with Dr. Kalpana, whom I see. Dr. Kalpana?
Yes, sir.
Could you tell your reactions to the conference?
Okay, I am the part of the team, though indirectly. However, I really want to congratulate and place on record a very, very finely developed and carved plan and executed with much more precision and much more efficiency. In fact, I was the one who asked the question that is it being managed by some event managers? Because whether it was a talk, it was a link of the talk, it was the speaker's details, or the symposium, the topic, everything was so well managed that in the middle of the night, actually around say 5 o'clock early in the morning, I sent a mail, and Nishita, I think she's there in the audience somewhere, she replied immediately, ma'am, don't worry, it'll be taken care. I was surprised. I was anxious because my talk and duration was not known to me and topic was misprinted. So such fine details and nuanced virtual conference. Sir, hats off to the team under the able leadership of Brigadier Saldana, Karan Chaudhary, and President Brigadier M.S.V.K. Raju, sir. It goes without saying that he was the one who was motivating us to go for the conference, and with not 1.5 days, 2.5 days with full deliberations and complete accolades. So I really, sir, hats off to you and hats off the team, and really congratulations for a well-executed conference. I can say very well.
Thank you very much.
One more thing, if I'm allowed to say, the choice of the topic and the speakers were excellent. I mean, we could have eminent speakers across the globe, not only within the country. And I think I can see a lot of instrumental aspects from Brigadier MSP Raju sir of collecting the speakers from far and wide and distant places, in Brigadier Saldana and Colonel Chaudhary, where they have selected such nice speakers, treat to listen to, intellectual treat as well. Not only visual treat, it was an intellectual treat. So both ways, it was a very rich conference. If I recollect, in the history, it goes as a first virtual conference and very well executed, sir. Thank you, sir.
Thank you, Kalpana. Thank you. Anyone else would like to say a few words? Tahura, you are requested to say a few words about your experience. From there only you can talk. Oh, Batista is there. Yeah, come. Come here. The first time you have done a conference. Supriya, come.
Very good evening to everyone present. I'm extremely humbled to be standing here in the view of so many eminent personalities and to be putting across my view. I'm extremely honored and grateful to be the MC for this event, and with the guidance of Jaideep sir, Saldana sir and Chaudhary sir, we could create a script and run it through efficiently. Thank you.
Thank you. Supriya, come. Supriya, nobody is there? Supriya, please come. Nobody else is there? Supriya Davis.
To all the delegates.
No, before Supriya starts, she is the granddaughter of Major R.B. Davis. We are honored to have her as our student.
Very nice to see that.
Yeah. No. Supriya, come.
Good evening to all the delegates present. We are all very grateful to get this opportunity for organizing this conference. This is the first time for us. Under the guidance of Dr. Saldana, Dr. Chaudhary sir, Dr. Jaideep Patil, Dr. Archana ma'am, and everyone who helped us out. It was a very enriching experience because in future, if we have to organize such a conference, we'll have an experience of what to do. Thank you for the opportunity, sir. Thank you.
Thank you.
Love. I was the one who was changing all the slides.
Thank you everyone for giving me the opportunity.
Dr. Love was in charge of the slides
changing the slides. And he was the one who was responsible for the efficient speeches by all the delegates from India and abroad. He made it possible.
And I were extremely fortunate to have been guided by Dr. Chaudhary, Dr. Saldana, and Jaideep sir. And it was a very good opportunity to develop our skills in military management.
Thank you.
Anyone?
Batista is here.
Batista, you tell your experience about the oral presentation now.
It was a very nice conference, and oral presentations were very good. And I also did an oral presentation, and it was very nice. Other oral presentations were also very nice, and very thanks to Dr. Daniel Saldana sir and Suprakash Chaudhary sir and others sir and ma'am for the conference, conducting the conference.
Thank you. We are starting. We are all
It was quite well organized, and I can now say that this conference was successful. I never imagined that online conference can be such a well planned. It was running before time on day one. It is very unusual to have such events occurring on time or before time. It was well managed, and it goes to Dr. Jaideep Patil, Saldana sir, and Chaudhary sir, and all our junior residents who have worked all throughout day and night. They were available on their phones. They were constantly messaging, texting, and giving comfort to everyone around. Thank you very much.
I request Dr. Brigadier MSV Raju to say a few words.
First of all, I would like to congratulate the bunch of stunning girls and the boys behind them for putting up a wonderful show. I have disturbed them in the morning, in the late night, evening, and every time in the day. They responded with great elan, and they were not frustrated. Observing their performance while the show is going on, some people were getting upset, but they were unruffled. Great show of maturity and wonderful experience to have such young and dynamic and very well mannered people as in the coming up in psychiatry. Well, secondly, from my point of view, it is an honor itself to head the association over the last 3 years at the fag end of my life. But I never expected any award. I expressed it also, but it is very graceful and generous on the part of the board to select me for this award. I am very, very grateful. The conference itself was managed very, very wonderfully, and we are very fortunate to such a large number of overseas faculty, and I particularly thank all of them. They are from all continents, from USA, Canada, UK, and Australia, and very short notice they came up and they enlightened us with their brilliant lectures. Thank you very much, sir, all of you. And from our own country, some brilliant speakers that come. I particularly thank Dr. Gautam Saha, esteemed Indian Secretary, for taking time off to chair the session which I spoke on fish, exclusively for him. Thank you all. God bless.
Just a reminder to all delegates. A few people have already been asking, and more will be asking about your delegate certificates. Kindly do not worry. We are on the job. We are trying to design a better type of attendance and presentation certificates under the guidance of Dr. Jaideep Patil. And I hope by the end of March, all the certificates along with the credit points and all the certificate for awards will be reaching your email. Please don't worry. By the end of March, all will be with you. I think
announcement.
Ask Dr. Jaideep Patil to propose a vote of thanks.
Good afternoon, everyone. It is my honor to propose a vote of thanks for 18th Annual National Conference of Association of Industrial Psychiatry of India. At the outset, we are extremely grateful to the Honorable Dr. P.D. Patil sir, Chairperson of Dr. D.Y. Patil Vidyapit Society, Pune, for permitting us to hold this conference at Dr. D.Y. Patil Medical College, Hospital and Research Center. I express deep gratitude to respectable Mrs. Bhagyashree Patil, Vice Chairperson of Dr. D.Y. Patil Vidyapit Society, for her constant guidance and encouragement. We are also thankful to Dr. Yashraj Patil, Treasurer of D.Y. Patil Vidyapit Pune, for the valuable support. I would like to extend heartfelt thanks to Brigadier Dr. M.S.V.K. Raju for his energetic leadership, unwavering support, and eternal encouragement. We would like to thank all HODs, faculties, and students of Dr. D.Y. Patil Medical College, Hospital, and Research Center for their enthusiastic participation. We express gratitude to our head of Department of Psychiatry of various colleges to allow their faculties and students to participate in this conference. We thank Dr. Sridhar Sharma for honoring this occasion with his presence. We are very grateful to all the invited speakers and more than 260 delegates from all over the world, without whom this conference wouldn't have been possible. We are very thankful to our colleagues who were efficiently handling all the OPD and IPD related work while we have been caught up with the organizing the conference. Special thanks to residents of Psychiatry, Department of Psychiatry of Dr. D.Y. Patil Medical College for being the wheel of the carriage, which was our conference. We also thank all the supporting non-teaching staff as well as technical staff for providing facilities for smooth conduction of the function. We also thank Sun Pharma for their support. Last but not the least, we thank the Board of Directors of Association of Industrial Psychiatry of India who allow us to hold the conference. Thank you.
With that, we come to the end of this function. Thank you all.
Thank you.
Okay.